My name is Jörg Hausleiter, and I welcome you to this early morning session on tricuspid interventions. Yesterday, a good friend of mine told me that he was a little bit disappointed about the program because it's not really showing some new excitement therapies, but this will change today, I guess. During the entire day in this lab, you will see some interesting cases about tricuspid interventions today and what the future will bring. And we're starting this day with a very exciting session about the Edwards Transcatheter Trilogy, an exclusive portfolio of 3 options to treat tricuspid regurgitation. I have a very nice distinguished panel with me. I'm going to start to introduce first Volker Rudolph from Bad Oeynhausen, then Andreas Rück from Stockholm, from Sweden, Philipp Lurz from Leipzig. We have Maurizio Taramasso also as a chat master. And last but not least, besides me, is Fabian Brav from Bern, who's going to be the co-moderator of this session. The session has the following objectives. We want to discuss and explore transcatheter therapies for the treatment of tricuspid regurgitation and their clinical impact. We want to participate in a recorded live case, which has been recorded in Leipzig a couple of days ago. And finally, we want to discover the potential of transcatheter replacement technologies in the future for the treatment of tricuspid regurgitation. And with this, I'm going to hand over to you, Fabian.
So good morning, everybody. Good morning, Jörg. I just want to remind everybody to participate in that session. It should be an interactive session. So please ask your question. I have an iPad here, and we look at your question online or on site in the room. And we'll be very happy to give priority at any time to your burning question that we will answer in the panel.
Okay. So I think we're going to start directly with Philipp Lutz. He's going to show us a case, the presentation of the patient actually, and then we're going to go into the discussions about what can we offer for such patients. Philipp.
It is an 81 years old lady with a severe dyspnea in New Heart classification 3. She had a bruising edema and she was recurrent hospitalized in our hospital for many times. It was at 2020, she received percutaneous mitral valve commissurotomy for a severe mitral valve stenosis. She had a persistent atrial fibrillation, coronary artery disease without any stenosis, diabetes. You can well see the current medication with 2 diuretics. Echocardiography showed good left ventricle function and very good result after mitral valve procedure with trace mitral valve insufficiency. Right ventricle function is reduced with severe tricuspid valve regurgitation. Coronary angiogram showed good results without any signs of stenosis of coronary arteries. And the functional test, 6-minute walk test showed 254 meter with severe dyspnea. Pro-BNP was increased also more than 2,500. She had also a reduced renal function and ARIA score 2, 20%.
Hello. Also from my side. So here you see the 4-chamber view with a massive dilated right ventricle. You see the apex is much larger from the right ventricle than from the left one. Here you have the X-plane where you see a dilated tricuspid annulus, which we measured with 46 centimeters, both directions, biplane vena contracta. We measured also with 11 millimeters, which is severe to massive, and the ROR is 0.5 square centimeters. In the 3D plane, you see here the tricuspid valve with color, and I will show you in a second the tricuspid valve without color. It's here where you see the pathology. Just to repeat, that is the aortic valve, so that is the septal anterior commissure. You have the septal leaflet here, the posterior leaflet here, and the anterior leaflet here. So that means it's a true tricuspid valve with a severe to massive tricuspid regurgitation, which also reflects the backflow in the liver veins, the systolic backflow. And with that, I want to give back to Professor Lurz.
So what we also see here is a transgastric view. Not only for planning, but also for performing the procedure, this is one of the most important views. So the viewer sits here at the bottom of the right ventricle.
And our proposed strategy in this case was to implant a Pascal ACE device, starting anteroseptally, and then see what we will get with the first implant.
Okay, thank you very much, Philip. Now, let's start a bit discussing this patient. Perhaps, Volker, is this a patient which you see also regularly in your daily practice? And if so, what kind of preparation do you do for such patients in the screening process?
Well, I think it's a very good case, but I think it's particular in that it's a patient with mitral stenosis, which we don't see so commonly. Most patients we see are, I think, HFpEF patients who develop atrial fibrillation and then tricuspid insufficiency based on annular dilatation. But I think this is the mechanism is the same here. It's really annular dilatation. We saw very little tethering. So I think, yeah, it's a good case to go for Pascal, but I think it's a case where we can also discuss the other techniques. It should be accessible to annuloplasty and replacement as well. I mean, this is something we should discuss. I mean, preparation of the patient, of course, is, I think, very important, we know that TR is very dynamic in nature, so we have to, when we do the screening echoes, we have to be sure that these patients are on stable medication.
Perhaps, Andreas, a short question for you. Would you discuss such patient with your colleagues from the surgical department?
Yes, we would always discuss them in the MDT meeting, but I think for a patient with this risk profile and this age, I'm pretty sure they will not be happy to operate on her. Okay.
Because you're going to show us very soon one of the first catheter options, I'm going to ask you, Philip, there are different options. We're talking about the Trilogy here today. What kind of options did you consider for this particular patient?
Well, I guess that there are three options on the table, right? So that's leaflet therapy, annuloplasty, or replacement technology. And as Volker said, theoretically, all three options are valid in that patient. But we do see that the gaps are within reasonable range. We don't have a severe tethering. We have anteroseptal TR, which nicely can be treated with leaflet technology, with edge-to-edge repair. What should be considered when you do these procedures that the TR extends also into the posterior commissure. So either you also do leaflet therapy there, or you implant enough devices anteroseptally, which will not only give you leaflet therapy, but at the same time reduce annular dimensions, which then also reduces TR away from the site where you implant your devices. That's our philosophy when doing leaflet therapies in TR.
Just one remark, more general one. I just want to emphasize the workup you have done in that patient. So we have seen you have done the right heart catheterization. You have looked at residual. It's a mitral stenosis patient, as you mentioned, residual pulmonary hypertension, which was not the case. And then the quality of the imaging was absolutely outstanding. So I think that's also a very important point for our audience to be aware that you will need to refer the patient already for the workup to have a specialized imaging as well, 3D of the tricuspid valve, the appropriate view to be able to then come to a conclusion which device you will use.
Well, talking about devices, I think we're now starting with the first device, which Fabian now will introduce to us, the annuloplasty device. Fabian.
So thank you very much. So yeah, my task here is to show you a little bit what cardioband can do in that kind of patient. We have discussed, there are some anatomical characteristics that will help you to decide which is the best therapy option in that patient. And in some of your patients, also cardioband can be an option. So annular reduction is the goal of that therapy to improve leaflet coaptation, enable annular reduction through standardized procedure that you can adapt to the anatomy of your patient, and you have also real-time confirmation by echo, which is usually TEE during the procedure. So it's a procedure done, of course, under general anesthesia. So if we look at the treatment result, which is a post-market study of the Cardioband, what you can see is first an annular reduction, which is the goal of that therapy. That's durable and that's effective. You see here 30-day result, but there are also longer-term results showing that this annular reduction is effective with the Cardioband. And this result into a reduction of tricuspid regurgitation. You cannot expect, the patient we are treating a patient with very severe TR, so you will not have mild or trace in all patients. But what you can achieve is to go down to moderate in about 70% of the patient. So that's a constant result across the different study with the Cardioband. And as you see, about 80% of the patient have a reduction of at least 1 grade, which we know actually correlates also with improvement in terms of functional capacity and quality of life. What tells us the real-world experience? I think that's very important as well. There are some publications. What we know now is that transient or acute right coronary artery deformation occur in about 1/4 of our patients. But we also don't know that this change in the anatomy of the right coronary artery are reversible. So if you re-angiography the patient after the procedure, then you will see that most of these changes are away, and that this does not lead to any kind of myocardial infarction or ischemia. What I want to emphasize also is that across the studies, the patient treated with Cardioband have more severe tricuspid regurgitation in terms of regurgitant orifice area than the patient included in Triluminate, for example. So what you see here is a reduction that is comparable between therapies, but patient refer for Cardioband start with more tricuspid regurgitation. And what we learn also, because that's one of the limitations of that therapy, we learn that the duration of the procedure decrease with increasing experience. So we are in very experienced center around 2 hours, maybe a bit less for that procedure, implanting most of the time 17 anchors. So I think that's also an important improvement. I just want to show you a patient. So it's a 78-year-old female we treated on the left side. You can see here with a Pascal device, combined valvular disease. We had a good result, but the patient remained symptomatic, heart failure symptoms, despite of medical treatment, with severe tricuspid regurgitation 3 months after the mitral procedure. And you can see this imaging again. So we have a 3D en face view. We have this deep esophageal view with severe tricuspid regurgitation and quite a central jet, which is something that you would qualify, or your patient will qualify for annuloplasty. So that's our algorithm that has been published simultaneously to London Valve, and you can see that in patient with central jet location or patient with tethering and a larger coaptation gap, you can go for annuloplasty as an alternative to transcatheter edge-to-edge or a combined procedure. What you will need to do in addition to what we have seen in the workup of Philip is a CT scan with simulation of the implants related to the right coronary artery. And that's what we did at the end, direct annuloplasty, and you can see that we had a very nice reduction of tricuspid regurgitation with some changes in the anatomy of the right coronary artery after cinching, but as we know, as I mentioned, that are not linked to any ischemia. What is also very interesting with that therapy is the ability, to combine therapies, because you are not with TARE, of course, you are modifying the valve. With the annuloplasty, you are working with the annulus, and you can combine that therapy. You have to inform your patient up front that maybe, like in that case with a pacemaker lead as well, one therapy will not be sufficient, so you reduce TR with the Cardioband, and then you implant, for example, here P10 Pascal with a very nice result that was also durable at 6 months. So let me conclude by saying that the post-market data shows the feasibility of that therapy of Cardioband. We have at least 1 TR grad reduction in more than 80% of the patients, septolateral annular reduction as well, and this correlate with improvement in heart failure symptoms and quality of life. And finally, combined procedures are also attractive in patients with more than severe TR, but the patient need to be prepared to a second procedure. Thank you very much.
Thank you, Fabian. This was a very nice presentation and a beautiful case showing really what Cardioband can do for tricuspid regurgitation. Volker, I have a question. Since you're the expert for Cardioband on the tricuspid side, what kind of anatomic features do you look during the screening for to make them suitable for Cardioband?
Yeah, very important question. I mean, I think the main pathology has to be annular dilatation, and as soon as you have a lot of tethering, and particularly also a restricted septal leaflet, this therapy is not optimal, and you should look for something else. Although, I mean, in very severe cases, you can do a combined approach, as Fabien suggested. But these are the two things we mainly look for. Pacemaker leads are not so much of a hindrance.
You were talking about combined procedures, Fabien. How often is this truly necessary in your experience?
Not so often, but when we get experience, I think with the selection of the patient, we get a feeling of in which patient you'll be able to have a really good result with annuloplasty only. And so we have done, I would say, maybe 3 patients out of 12 we have treated with a Cardioband. So in most of the cases, actually, you are happy with the final result of the procedure, and the patient also, and you don't need to go for a second one. But I think it's important, to prepare the patient up front, to speak with the patient and family, and to gain their confidence as well in a second procedure, in the need of a second procedure. And most of the time, the patient are very happy as well.
Is this predicted? So you're going to plan with the patient up front that you're probably going to need 2 procedures, or are these patients where you had initially a very good result and then you had a return of the TR?
No, we did not observe progression after our annuloplasty cases. We had some cases that were less successful in reducing TR, but it was not a failure of the therapy. It was really an upfront discussion that we will need probably 2 procedures because the TR is just too severe.
Andreas, do you have experience with the Cardioband in Sweden?
Yes, we've used it. Of course, we would say here too that there's a limitation here to the size that you can treat. Of course, some patients who are just too large in size, even for the largest F-band. So that's a limitation here too.
But that's probably changing with the new generation, which is probably around the corner and coming very soon.
Yes.
And we were talking about complications. We saw these nice images about the right coronary artery, how these kinks resolved after time, in the repeat angiograms. Are there any other concerns about complications from your experience?
Of course, in the cases where it's difficult to place the anchors, and especially the first and last ones, and if then you have a disengaged anchor, then of course you have a problem and an imperfect result. I guess that's also part of the learning curve.
But there are also complications described like perforation, or you can also create a stenosis of the right coronary artery with a screw. In that case, you will see it. So it's mandatory to control the right coronary artery during all the implantation. You have a catheter, you have a wire in to be able to react as well. And you will see it. So you will see the screw going into, most of the time, the tissue around the right coronary artery, not directly in the vessel. And this can create stenosis. But in that situation, you can remove the screw and replace. And in some rare cases, you may have to implant a stent, which is, I think, now quite rare. It was rather at the beginning of the experience. And perforation can also happen, and in that situation, you need to be prepared to implant a cover stent, but I never had this complication so far.
Yeah, because the data so far show that this procedure is going to be a very, very safe procedure and can be successfully performed.
Yeah, I think the main issue is imaging. So, actually, from an interventional point of view, you have to be patient. It's a long procedure, but it's not a difficult one. But the imaging is the most tricky part. I think you agree, and you have to see it to be able to implant these screws. And the main tasks are the one from the imager.
Wonderful. So I think we have to continue because we have a second option for the treatment of those patients. It's also a CE marked device, and Andreas Rück will present the Pascal device for the treatment of tricuspid regurgitation.
Thank you for the invitation. I will walk you through some of the evidence and show you a short case on the Pascal for the tricuspid. As you might know, the Pascal system is available for mitral and for tricuspid treatment. It's the exact same system. The boxes are not marked MR or TR or anything like that. What we use, the implant that we use mostly for the tricuspid is the slimmer version, which is called the ACE. It has a width of 6 millimeters. Technically, it's similar to the 10 millimeter device in the way that it allows for individual clasping and grasping of the leaflets. You can open, you can optimize quite easily. You can steer in the same way as with the mitral system. You have 3 degrees of freedom on the steering. We think it's a quite friendly and gentle system. The catheters are rather soft when you manipulate them. You get a feeling on how firmly attached you are. So it's, in our experience, very hard to damage any leaflet or any cords with this system, which we think is quite important in the tricuspid. Looking at the data, there's a few studies out. This is a small study on compassionate use. You will see here that you have a success rate of reducing the tricuspid regurgitation on a 5-grade scale down to moderate or less of more than 75%. And looking at the symptom class and also a 6-minute walk test, you see some improvements there too. And then the second study is the early feasibility study, which shows quite similar data. And you see some patients here are followed for a bit longer time. And here also roughly 75% of the patients have a meaningful improvement of the tricuspid regurgitation. And here also you have numbers on the echo improvement, where the EROA and also the vena contracta goes down to approximately half in these patients, which seems to be a meaningful reduction. There's also data here on the symptom class, and here you see also on the scores in the heart failure questionnaire, where we also see an improvement. The biggest data set out is this that was presented earlier this year. It's patients in the registry from Germany and Switzerland, over 200 patients here, so it's much bigger than before. And you see the numbers on the TR reduction are very similar to the previous studies that you saw, with about 75 to 80% of the patients who go down to a TR that is moderate or less. And also here you see symptom class improvement as in the previous studies. The average number of devices implanted here was 1.7. And you see that the procedure time is probably a little longer than in the mitral, but over 100 minutes in this case. I just want to show you briefly a case from our institution about a year ago, just walking you through the steps that we used in imaging also. So it's mainly guided by Transesophageal Echo. Just the baseline imaging here, first in mid-esophageal view on the left side. You see that there is quite some regurgitation, and this one was graded as grade 4 out of 5 on the scale. And then going down with the probe to the Transgastric View, where we have this nice short axis cut of the right ventricle, just to orientate everybody. Up in the image is posterior in the patient, so there we'll see the posterior leaflet, and we have the anterior leaflet, and we have the septal leaflet. And just looking at the color distribution, we see a similar case, I would say, to the one that was shown from Professor Lurz in Leipzig, where it seems like most of the color is in the anterior septal commissure, but not all of it, and it extends also up to between the septal and posterior leaflets. So in this case, you could also discuss how to place your devices. Our default strategy is to start from septal anterior, march towards the center of the valve, and potentially put something between septal and posterior, but usually that's not needed in our experience in these cases. And then just coming in with the first device, like in the mitral, you check the trajectory so that you go straight to the valve. And then you check the clocking as well, of course, and the clocking should be around 90 degrees to the commissure line. And just like in the mitral, the commissure line is not a straight line, but it's more like a C. So here you see that with this device, we start approximately midway between the septal posterior commissure and the commissure between the septal and anterior, which is at 5 o'clock. So approximately mid-leaflet on the anterior leaflet here. This video, I think, will be quite blocky. It looked better on my computer. So it's just to show off the eyes use. Unfortunately, with this recording, it doesn't show quite nicely. There will be another session today where my colleague Chris Maduri will go more into the detail of using intracardiac echo for these procedures. We think it's an improvement for the grasping. It doesn't look like this on that video, but the original was better. So I'll skip it for the eyes discussion for another session. Then going back to transesophageal echo, usually we use 2 devices, sometimes more than 2. So the second device should be clocked similarly to the first device. And you see here we place it more centrally, more upwards towards the posterior leaflet, but it's still on the anterior leaflet. We grasp and we close. And then there's a final assessment where you see that the insufficiency that we previously saw between the posterior and septal leaflet is mostly gone without touching the posterior leaflet actually. So that strategy seems to work quite well and then does this so-called indirect annuloplasty effect in many patients. To conclude, this Pascal system for repair of the tricuspid valve seems to be efficient with rather similar numbers in 3 studies now, with about 75 to 80% of patients going down from a more than severe tricuspid regurgitation to a moderate or less tricuspid regurgitation. And we see meaningful reductions also in the symptom scores and also in the NYH class of the patients. Thank you.
Thank you very much, Andreas. It was a beautiful case and a very impressive reduction of the tricuspid regurgitation. Perhaps, Philip, I'm going to ask you, there are 2 devices out there, the classic P10 device with 10 millimeter width and the smaller ACE device. How do you select the device according to the patients? Do you have a favor for one of those?
Yes, there's certainly one device we favor, and that's the P5, so the Pascal ACE device. When we do tricuspid interventions, that's the device with a smaller width. The reason why this is now our default device when we treat TR is that I think it's easier to maneuver in very dense cords, and we know that in most patients, the subvalvular apparatus of the tricuspid valve, it's crowded. There are a lot of cords where you could get entangled in, and therefore the device is our preferred choice. The other consideration which could be made, but that's a little bit more complex, is a discussion about the central spacer. It seems to be smaller with the ACE device, but the spacer is a good thing to fill in coaptation gaps. But when you have with the ACE device a smaller spacer, then you might be able to bring the leaflets a little bit more together, have more grasping force, and that's something which is important when treating TR, because we do not want to do leaflet therapy only, but as said before, one of the concepts why the therapy works so well is that we get also indirect annuloplasty effect by pulling over the free wall of the right ventricle towards the septum. And that's why it's also important to always connect the anterior or posterior leaflet with the septal leaflet.
So yeah, there are some questions from our colleague online. And the first one from Dr. De Giovanni is about a patient with a pacemaker. So what is the best treatment option for pacemaker patient? Is it edge-to-edge or is that annuloplasty? Volker, what do you think?
Well, I think it really depends on the pacemaker lead. I think in general, a pacemaker lead is not a hindrance for any of the procedures as long as there's not real interaction. In the rare cases, one must say, where there is true interaction, where you have, impingement of a leaflet, this might even be a patient who's not accessible for any of these therapies. So it really depends on the exact situation of the leaflet.
And there is another question from Dr. Haga from the room. He's congratulating you on the result, Andreas. I think it's a question for you. But he's asking about single leaflet device attachment. What is the situation there in the study, in the data we have regarding that issue?
It happens. It seems to happen if you're paying attention to the imaging during procedure. It doesn't seem to happen much more often than in the mitral, actually. And that's personally where we at our institution think that maybe ICE will help, since there you really see it exactly how it goes in. And that's also coming back to the device discussion. That's maybe also an advantage of the ACE device, because this central spacer gives you a much smaller shadow on the echo, so it's more easy to see if you use the ACE too. So we think it's quite safe. And in our institution, we have not had any single case so far.
Oh, that's fascinating to hear. I think we have to continue with within our program. We have seen now 2 devices which are already CE marked in Europe, so which we can use in daily practice. But now we will have a glimpse into the future, and Volker Rudolph will give us a presentation on the option number 3 of our trilogy, the future treatment of TR with the transcatheter tricuspid valve replacement system, with the results from the Trisense Study. Volker.
Well, thank you very much. It's my pleasure to talk in the next minutes about the EVOQUE system for tricuspid valve replacement. As we heard, this is an investigational device which is not CE marked, so I will mainly talk about the results of the Trisense study, the 6-month outcome data, which were recently presented by Sushil Kodali in a late-breaking trial session at TCT in 2021. So this is how the device looks. It's a nitinol frame valve with pericardial bovine tissue. It has 9 anchors, and it's brought toward the valve via a transfemoral approach with a 28 French sheath. It has 9 anchors. As you can see in the animation, these anchors are thought to be engaged with the tricuspid valve, and then the valve is released, seeking for stabilization of the valve by slight oversizing of the valve, and also by interaction with the chordae, and also sustainment by the papillary muscles. The Trisense study, which was performed in the US, was a prospective single-arm multicenter study which sought to evaluate safety and performance of this system. There was rigorous trial oversight with several committees, a core lab, which looked at the data. Patients had to be symptomatic with at least moderate tricuspid regurgitation. Both functional and degenerative etiologies were eligible. Exclusion criteria were overt pulmonary hypertension, as you can see on the left side, and also an LV ejection fraction below 25%, a severe renal impairment. Endpoints were device and procedural success, as well as major adverse events at 30 days, and TR reduction, of course. As I said, we will see here the 6-month results. There were a total of 132 patients enrolled, which is remarkable for an EFS trial. We have the follow-up data of 56 patients available here. You can see the baseline characteristics in the table. Patients were 79-year-old. A lot of them were female, and I think this is something we can discuss later. TR was severe in 88% of these patients. Patients were high risk, as shown with the STS mitral score of 7.4. Almost all of these patients had atrial fibrillation, pulmonary hypertension with a PA pressure above 30 in 79% of these patients, and really a lot of comorbidities. High percentage of patients with prior valve surgery, 38%. High percentage of patients with pacemaker or ICD leads, 35%, and most of these patients had functional TR etiology. With regard to procedural characteristics, all of these procedures were performed percutaneously. Device success was achieved in 96%, also remarkable, I think, for such an early stage. Device time was about 70 minutes, and the length of stay in the hospital was only 3 days. And I think very importantly, considering how sick this population was, above more than 90% of these patients were discharged home after 3 days. This table displays the major adverse events at 30 days with a 30-day cardiovascular mortality of 2.4%. Only one patient with renal complication. You can see that the most dominant adverse event was severe bleeding in 22 or 17.7% of patients. Although, and this is important to mention, there were only 2 patients with major excess site and vascular complication-related bleedings, which I think is very important to mention, also something to be discussed. It's also very good to see that overall MACE rate was only 18.5%, so over 80% of patients were free of any MACE at 30 days. All-cause mortality was 3.2%, and there was a pacemaker rate for permanent pacemaker of 10.5%. Here you can see the reduction of TR severity, which was 97% at discharge and 100% at 6 years. This is a replacement therapy to none or mild TR at 6 months. So it really does what you expect. And what is maybe more important is that there was a very low number of adverse events after the procedure in the 6 months of follow-up that are available at this time point. And this, of course, is also reflected by a very low mortality rate during this time point, and also, even more remarkably, a very low heart failure rehospitalization rate. There was marked improvement in functional outcomes and also in quality of life. 89% of these patients had a New York Heart Association functional class dyspnea of 2 or less. 6-minute walking test increased by 56 meters, which is quite a bit more than we see in comparable therapies, and also improvement in quality of life with 27 points is above the usual average we see in comparable therapies. So to conclude, this very new system and not yet approved system of tricuspid valve replacement demonstrated favorable 30-day outcomes, which really showed sustained results at 6 months. Well, there was a very clear elimination actually of tricuspid regurgitation with high survival rates and freedom from heart failure hospitalization even at 6 months, and significant improvements in quality of lives and functional status in these patients. And based on these results, as you know, the randomized pivotal trial, which is run in the US and in Europe, is currently underway. Thank you.
Thank you very much, Volker. It was a very nice presentation. I think we're going to continue. Philip, if you're going to prepare yourself for the next presentation of the patient, I'm going to ask Fabian just a short question. If we consider that this device is probably going to be available in the market in 5 years from now, how big do you think is the percentage of patients where we're going to treat those patients with a replacement system instead of a repair? Do you have any idea?
I cannot tell numbers, but I think what you need to consider in that situation is the ease of use of that therapy. So you don't need to know the anatomy in details. You don't need to name the leaflet, and you replace the valve. But there are some limitations. So still, a lot of patients are refused because of the size of the annulus. The valve is not suitable for all anatomies. So it's a complex workup of that patient, also involving CT scan. And the way is long until we will be able to treat every tricuspid patient with that replacement. And there are also other limitations. I mean, anticoagulation, antithrombotic treatment is obviously something that is less a problem in transcatheter edge-to-edge repair. So, you know, there are some issues. It's very attractive, but it will not be for every patient soon.
So now we have seen all the three different devices, the three different options, which we will have in hands in the very near future. Now we want to see, Philip, what did you do to your patient?
We check the path, we move in and out the device and see, especially on the left, whether it crosses the tricuspid valve more or less in a 90-degree fashion, which it does. That's good. We can open the device. I will cross the valve in a second with the device being closed, but I'd like to get some idea about the clocking before we cross. Okay, that seems to be fine. And we can do an independent clasp check. So this one, Sergey brings down this one. This one is the septal. Can we have the, exactly? And this is the anterior. So the task is now to remember which one is which. Okay, then we close the device, please. So our target area here is antroseptally, as said. So cross the valve now. And then we ask for a breath hold, please. The device is sort of in a 7:30 to 8:30 or 7:45 to 8 o'clock fashion, which means that it is pretty much 90 degrees to the line of coaptation between anterior and septal leaflet. I believe that the septal leaflet is already engaged on the device. The orientation is fine. The position should be fine as well for a second device to be placed antroseptally. So I guess we can move up now and go to a grasping view. It's not that difficult to get the leaflets in, but we really would like to get it perfect and as much as possible. Okay, so anterior is, I prefer to have a bit of a V shape, exactly. Okay, so anterior is in, and now I move over to septal. Because of the, hold on, because of the sort of curling of the septal leaflet, we now change the strategy and do stage grasping. Can you move the cursor and echo a little bit? Okay, so septal should be in. Bring it down, and then close the device, please. Slowly. Okay. So we close the device. We see that tension on the leaflets is nicely building up, which is normally a good indication. The device is closed now. We restart breathing, please, and then assess everything carefully. So remember, the strategy is to place two devices, but not necessarily at the position where we have the largest TR chat, but place them in a way that we not only do leaflet therapy, but at the same time get indirect annuloplasty. And because of that, it is important to get as much leaflet tissue in, but also get the clocking right. So these are also things we have to assess for very carefully now. Another question at that point in time is always, does it make sense to do a single leaflet optimization, trying to get one leaflet in even further? But I'm curious to hear your opinion, but I don't think it's necessary. They're both nicely in.
They're deeply in. The septal leaflet is in the device until the hinge point. And it was already long and curling into the device, so probably there's no way to improve it further there. And also the anterior leaflet was deeply in. You see some secondary cords just where the device starts. So I would be very happy with such a.
On a transgastric, sometimes you have to be careful because between a device and antroseptal commissure, you will have shattering and might underestimate. But here on that view, we should not get not too much shattering. So what we see on color is normally what really is there. So it's not the risk of underestimation in this view should be small. Okay, then we are happy to release. By turning the knob, we release the device as now. We see on fluoroscopy that everything is stable. It's not rocking. It's moving within the cardiac cycle, but it's connected to both leaflets. Otherwise, we would see a completely different appearance. So you see RA pressures. EN is 12, no relevant V wave. So that's reassuring. What do you think? That looks pretty much what we had before release, right?
Yes, so it's a minimal jet septal.
Yeah, it didn't change significantly.
Which is good. I mean, I guess we all were in procedures where it changed and...
Yeah. This is really educative because there are many people that do not understand really well how to assess leaflet insertion in this view. Obviously, you cannot measure it, like in the regular grasping view, let's say, but I think this is the most convincing view to check that you have nice leaflet insertion. I don't know what you think, but I really like this view, and it should be shown to all the operator to learn how to assess leaflet mobility and insertion in transgastric.
Yes, I totally agree. It's but it's the overall appearance. It's not so much, as you said, it's nothing you measure, but you.
Yeah.
It's the appearance, the interaction between the device and the leaflet, and also carefully assessing how the leaflet enter or leave the device.
But there's a technique which we are using is in this view. If you swing from the tip of the device to the arms, to the level of the valve plane, and then there, as an echocardiographer, you can also see how deeply those leaflets are in.
That is by advancing and withdrawing the probe? That is what you mentioned first?
Yes.
Is that true? Okay, and then I would change to the long axis?
But it makes the point that a good understanding of the imaging and the anatomy and sophisticated approaches of how to assess it are extremely helpful, because they give us the confidence to implant and release the devices.
And then you do it with the explain.
This is a way you can do it, yes, as a potential to swing from the tip, so from the RV, yes, to the valvular plane, and then you should see on the right side how the leaflets are getting into the device. It takes some time to get used to this kind of view, but it is a potential also to use the Transgastric View to look at leaflet insertion, besides the overall impression.
Great. So this is live teaching and application of it.
We are at Karolinska always using intracardiac echo to assess the leaflet insertion when we grasp. Only that step. I know that's maybe quite unique, but I think for some reason the imaging quality is slightly better. You see the leaflet in itself maybe more clearly going into the device.
So you use intracardiac echo for all of these cases?
Yes, all.
Could you share some of your experience? Is it a game changer or just a little thing, nice thing to have?
It's the confidence, because usually you see the leaflets themselves more clearly going into the device. The downside is that with the current generation ICE devices, you need to do quite a lot of manipulation to get the right image plane manipulated. So it probably adds a little time to the procedure, but we feel that it might add a bit more safety with the lower risk of having a SLDA or a similar problem.
It's very interesting. So the implantation of the second device follows the same steps as for the first. Some aspects are easier because the first device is a nice landing zone, and the dynamics of the valve are a little bit reduced by the first device. But then the downside is that obviously one should avoid to get entangled with the first device. Okay, so breathing stop, please. We cross slowly. What we also now going to do is, while the probe is positioned at the perfect spot, we use fluoroscopy. So obviously this procedure is guided throughout by echo, But at the same time, we can also guide echo a little bit by using fluoroscopy, which then helps to find the ideal position of the probe. And that makes things much faster to finding the right position. Okay? I think we are fine here. We can open the device now. Okay. More. Okay. Again, we don't see the device open now on echo, but that's fine. But we see the level of the cooptation of the leaflets. I move in the system a little bit to be very close to the first one. And now I bring back the device. I use fluoro for you to appreciate that. And then every second we should be able to appreciate the clocking of the device on echo. So at that point in time, because I have the leaflets on, I'm very close to the first device, I'm hesitant to do too much of motions from anteroseptal to posteroseptal, but I could move in again, get the leaflets off the device, and then move away. But maybe we try it like this first. Everything is stable. I could close it here, but I still prefer to do it in a grasping view. So echo, please. At that point in time, also the question always is how much you pull it up into the leaflets. It's probably enough. Sorry, I closed it too much. Can you open it a little bit, please? Yes. Again? Yes, okay. And then we bring down the clasps simultaneously. Okay. What do you think? We could close, couldn't we?
Yes.
Yeah, okay. Then we close slowly. Okay. Okay. It's closed. Not quite yet. Now.
And the mean gradient was 1. The peak was 2.
It's another thing. If you treat anteroseptally only, then you hardly ever have a gradient. But then it can then rapidly jump up once you involve the third leaflet in the therapy. Okay, so we try to appreciate now whether we have any distortion. We're still about to find...
How does it look on fluoro? Are they parallel devices? You could get the impression that maybe the clocking changed a bit.
Yeah.
I agree. I think the clocking could be done better.
So would you then think that the second device needs to be counter-clocked a little bit?
Yes.
Like half an hour?
Yeah.
Okay. Yeah.
May I suggest we do another breath hold and then we open the device, which then helps us to understand the clocking a little bit better, and then we decide what we do. And we open the device with the clasp still being down, and then we can decide whether we bring them up or not. Okay, we bring up the clasps both. All right. Okay, I turn a bit. All right. Good. Then we bring down the clasp simultaneous again. Okay. And then we close the device. Okay, I think there's no doubt that tension is building up. Okay. Okay, breathing on, please. So what you see now on the right-hand side, now here you see the anterior leaflet nicely in the device. And if we then go with the cursor a little bit more to the left, further left, and now we think that, oh, the leaflet is not in. But this is where the anterior goes over into the posterior. So whenever you grasp the leaflet right at the hinge to the next leaflet, it is important to use the cursor on an X-plane view and assess it carefully. So I think it's in, don't you think?
Absolutely.
Okay. So one last check on color, and then I guess we... Okay. So obviously we see some color, but from a vena contractor point of view, it's not much.
No, because that is the major axis. So I would agree that the amount of TR is significantly reduced. And it's just a tiny jet.
Can we just, could we remind ourselves of what we started with? So can we see baseline again, please?
Yes. This was where we started with.
Yeah.
So huge one.
Okay. So I think we are, so that's mild now, right?
Yes.
Okay. Which is fine. So remember that a TR is graded now from 1 to 5. It should be brought down always to moderate, better to mild. We have mild, so that should be fine in terms of patient symptoms. We release the device now, and then we do a final assessment. What's also sometimes observed is that after release, the anatomy moves a little bit more towards posteroseptal, because with the implantation we push it towards anteroseptal. And this can increase the gap centrally. And I think this is exactly what we see now. So at least I believe after release, it's now a bit better than before release, because the two devices moved a bit more centrally or posteroseptally. Do you share that experience and observation?
Yeah, absolutely.
Okay. Perfect. The result looks very good now.
It's better. It's much better.
Yeah. That should be fine, especially if we bring it down to patient perspective and what it means for her symptoms, her daily routine. We certainly removed the TR chat anteroseptally, but also removed the anatomy in total and reduced TR posteroseptally and centrally. We would expect to see exactly the same tomorrow morning when she gets her discharge echo, and then hopefully she'd be home tomorrow afternoon.
Great case.
Wonderful images, great result.
And really educative. Thanks.
Okay.
Congratulations.
Great case, Philip. So now we have seen in this live case more or less all three modes of actions of the Pascal device: the simultaneous grasping, the stage grasping, and the optimization procedure. Can you tell us how often do you use these in your practice?
Very often, all three of those, especially in complex anatomies. The way the device grasps the leaflets, the fact that it's flexible and overall, I think, quite gentle to the leaflets, allows us to do multiple grasping maneuvers without being too scared about injuring the leaflets. And this is why we do that quite often. And as we've seen also in this case, I think it's worth to be very accurate. And even if you think that the clocking is fine, if you're not happy with the TR result, sometimes it's really worth to do small optimizations, because you will be rewarded by a better result.
Now we have seen all the three different options for treating such patients. Will we still go with a Pascal procedure? Volker, what do you think? Would be a perfect case for a cardioband, wouldn't it be?
Yeah, I mean, it probably would work, but I mean, this was an really optimal procedure, optimal result. So I think it's difficult to argue that we should have used something else. And I mean, we have to bear in mind, of course, that as we talk now, this is the easiest procedure for the patient also. We don't have CT screening, we don't have contrast that we use. So, I mean, right now, if we can do edge to edge, that's probably the way to go. And we have to see what the future brings.
No, I think the anteroseptal location, mainly of the TR, is something really speaking for edge-to-edge repair, and I would have done the same. So I don't think it could be done with a cardioband, but maybe it's not an ideal one, or it's more adapted to edge-to-edge repair in that case. So maybe Jörg, I can thank you very much. I can summarize,
please.
I should summarize. So I think we have a very exciting session on the treatment of tricuspid regurgitation, and we have seen the different treatment options, which include annuloplasty, edge-to-edge repair or leaflet approximation with mainly the ACE device, and also the future of replacement. So I think looking at the anatomy of that patient, selection of the patient, all these three therapies will play a role. We continue to play a role, and in order to best address the need of different anatomy and patient. So I hope you enjoy it on site and online. I wish you a very good day, Congress Day. Thank you very much.